Hello, everybody. Good evening, and thank you for joining us for Clinical Trends in Soft Tissue Healing, Insights from Scientific Literature. Thanks so much for joining. My name's Carly Watkins. I'm the Senior Product Manager here at Acera Surgical, and thank you so much for giving us a part of your evening. Tonight, we have a really jam-packed agenda with a lot of great content. We're going to begin by hearing from our Chief Scientific Officer, Dr. Matthew MacEwan. He'll give a little bit of an introduction on Restrata and the technology and the results that we're seeing. And then we're fortunate enough to have two surgeons on the line with us, Dr. Susan Hagen and Dr. Katherine Santosa, that will also go and share their clinical insights and what they're seeing from Restrata. And at the end of our presentation this evening, we're going to have a panel discussion and a Q&A from the audience. So again, if you have those questions, submit them, and we'll be happy to answer those at the end of the presentation. And with that, I have the privilege of introducing our Chief Science Officer and co-founder of Acera Surgical, Dr. Matthew MacEwan.
Wonderful. Thank you so much, Carly, for the introduction. Really excited to share some of the technology behind Restrata with everyone tonight, and also very excited to have Dr. Hagen and Dr. Santosa share their experience with the product and their practices in Colorado and in Atlanta, respectively. So, but with that, let me just start off. And for those folks who I haven't had a chance to meet out there, just want to do a brief introduction into who I am. So my name is Matthew MacEwan. As Carly mentioned, I'm the founder of Acera Surgical and currently serve as the Chief Science Officer with the company. A little about myself, grew up in Ohio, did my undergraduate work at Case Western Reserve University up in Cleveland, and got very interested in biomaterials and essentially how we can make biomaterials more compatible with the human body and work more in concert with the human body. Ended up taking that experience down with me to medical school. I went through the medical scientist training program, the MD-PhD program at Washington University School of Medicine in St. Louis. And while I was there, I had a chance to work in the lab of a gentleman by the name of Yunnan Shah. We got very interested in how we could use electrospun synthetic materials as a new type of construct for soft tissue repair and wound healing. And so about 10 years ago, when I was a medical student, we sort of invented this unique material. It became Restrata and started a small company. And here we are about 10 years later, and now have some of the very first synthetic alternatives and electrospun alternatives for use in soft tissue repair. So very excited to kind of share this technology with you all tonight. So with that, let me just start by kind of telling you a little bit more about the product and the technology we'll be discussing. So I would love to give a little more background into Restrata, how it's made, what it's made of, and how it's a little different than some of the other technologies and products that are out there for wound management and soft tissue repair. So Restrata is very unique. It's really the sort of the first of a whole new class of matrices for soft tissue repair. Restrata is the very first electrospun synthetic fiber matrix for use in wound management. For those of you who haven't had a chance to actually work with Restrata, Restrata feels almost like a soft, white, compliant, almost cloth-like material. When you hydrate it, it gets a little flexible, almost like native tissue. It's strong enough to suture or staple right into a wound bed. But the really unique thing about Restrata is there's actually no human or animal tissue in the material. It's only composed of these micron and submicron scale fibers that mimic or are similar to the structure of native extracellular matrix. So when you put Restrata into a wound bed, it provides this kind of unique scaffold for cell infiltration, vascularization, and tissue formation. And it gradually then resorbs, leaving that newly formed tissue behind. And the great thing about Restrata is now we're using it coast to coast, and we have some great level 1 clinical evidence behind it as well. So just to kind of go over the indications for use for Restrata, one of the nice things is Restrata is explicitly indicated for use in the management of multiple different types of wounds, so it can be used in many different places. Restrata is indicated for use in partial and full thickness wounds. It's indicated for use in chronic wounds, including diabetic ulcers, venous ulcers, pressure sores. And it can also be used in the OR and to treat surgical wounds. So have many different applications there, and also in traumatic wounds too. It's also indicated for use in first and second degree burns. There are two specific contraindications that I want to point out, specifically with Restrata. First, it is contraindicated in third degree burns, and it's also contraindicated in patients with a known sensitivity to resorbable suture materials. So folks who might be allergic to resorbable suture materials like Vicryl or PDS might not be the right patients for using Restrata. But the takeaway here is that Restrata can be used in a number of different places around your practice. So just to kind of highlight the unique aspect of Restrata, as you mentioned, Restrata is explicitly designed out of these submicron electrospun fibers, and it's designed to really mimic that structure and architecture of human ECM. So this is a great slide because it highlights that similarity that Restrata has structurally to human ECM. So in the middle, you can see this is a scanning electron micrograph of Restrata, and you can see it has that same fibrillar, non-woven architecture, just like human ECM on the left. And the really interesting thing is compared to some of the processed collagen-based xenogenic or human allogenic materials that are out there, it has the ability to sort of better mimic or better resemble that human ECM structure. And that's what really allows cells to attach and grow into the material so readily. So again, this unique technology, this electrospun technology really gives Restrata some unique properties different from other options that are out there today. So along those lines, just to kind of give you all a sense of what these fibers look like and how small they are, this is a great slide because it just shows you how small these electrospun fibers are and how well they mimic that native ECM. So on the left-hand side, this is a scanning electron micrograph of a human hair, a mode of pollen, and behind it, all these submicron scale fibers that make up Restrata. And on the right-hand side, this is a fluorescent image that just shows a orange human fibroblast actually growing on a layer of these electrospun fibers. So in general, the fibers are between 10 and 100 times smaller in individual cells. And what's really unique is that in all of our basic science research over the last 10 years, we've actually found that if you make the fibers this small in this sort of subcellular range, it actually changes how cells interact with the fibers, new tissue formation, and wound healing. So it's really the structure and architecture of Restrata that really gives it these unique properties, unique clinical applications in your practice. But with that, having talked a little bit about the basics of Restrata and how it's designed and how it's made, I'm very excited to sort of switch gears and have you hear a little bit more about how it's being used and some of the outcomes that have been achieved with Restrata clinically. So it gives me great pleasure to introduce a great friend and colleague, Dr. Susan Hagen. Dr. Hagen is a general surgeon in Boulder, Colorado, and serves as the director of the Wound Care Center and also the director of surgical services at Boulder Community Health. So very excited to have her share her experience with Restrata and one of her peer-reviewed publications here tonight. So Dr. Hagen, I will pass it over to you.
Perfect. Good evening, everybody. So excited to be here to share my data and my experiences from what I've learned. Couple things. I started the Wound Healing Center in Boulder, Colorado, not out of this huge passion for wounds, but maybe I was more tired of the Friday 4 p.m. consult for things that should have been dealt with maybe 2 weeks ago. And that kind of stemmed how are we better taking care of our patients and helping them reclaim their life and get whole and seeing them in all these different areas, and then learning how much at a wound healing center, how we are that point of contact that happens so frequently. I have a unique position in that we're a level 2 trauma center, and so I see a lot of badness inpatient, and a couple of things really attracted me to learn more about Restrata. One was it's the exact same product that's being used inpatient as it is outpatient, and there's not a change from that. And I thought that was really exciting. And then secondly, when I went to some of these meetings, I was so tired of hearing about kind of a different spin on the same thing, that this was new. And that was mainly the reason why I stopped by at the booth at all, was I hadn't heard anything like this, and this was different. And it made me think, is there something else besides a xenograft, an allograft, autograft even, that we can learn from? So I'm going to show some of my experiences. It's super exciting because I really tested the limits. I wanted to see, this is crazy, doubt this will work, and to see what it happened. Long and short of it, I treated a total of 21 patients with 24 wounds, but we pulled that down into 19 patients with 22 wounds. And the wounds were small, all the way up to big, 23 by 23 centimeters. And I really took full reign. I didn't make this just VLU, just DFU, but like, what about all these people who've had big things or trauma or a pilonidal cyst, a rattlesnake, horrific frostbite, like whatever it was, how can we help get them healed faster? And would this product even work? And the other thing I really wanted to do was achieve specific goals for the patient, because for everybody, it wasn't always complete closure. Sometimes it was a bridge to something else. And in one case, it was honestly palliative care to get it where this open abdominal wound would allow her to pouch. She was an end-stage cancer and had this horrific wound. And while on active chemo, could we get it so she didn't have poop everywhere for her family? And we accomplished that. And I think that's really important. We'll touch base about that again at the end to just see what is the goal that you're trying to achieve with each patient and how to help go there. So this is completely retrospective, and this is a large variety of wound etiologies, which makes it super exciting. But at the same time, of course, there's limitations to that too. And I had absolutely no control groups. So I'm going to just share a few of them. Okay, so this person was treated by a colleague of mine at the Wound Healing Center. And this guy is 60, diabetes, morbidly obese, sleep apnea. And he had had these wounds 14 months and 26 months respectively. And it just happens to be the day I'm inpatient at the hospital. I was like, I've got this new thing. We should maybe try this. And I thought, there is no way this is going to work. I mean, like, this guy needs a lot of help. So the first thing I did is debride. And I really believe firmly in debridement. And if you do nothing, I believe that debridement is going to get you a lot further. So one leg is horizontal across the top. The other leg is horizontal across the bottom. And you can see on the second picture there, they look healthy, red, bloody. We love that. And then I fenestrated the Restrata because these were venous and there was a lot of leaking and I didn't want to deal with that. And then I took these pictures later to just show it kind of degrades a little bit into the wound. But I was completely shocked that one healed a little over a month and the other took a couple applications and it was 40 days. Like, this is crazy. And I ran into him recently, and he had another wound, different area, just to be clear, but these still looked great. And I don't know, I'm still shocked about this one. It's amazing. And I found that a complete win, and it was exciting that we could accomplish this for this guy inpatient. Okay, so something totally different. This was rattlesnake bite, and she's 71. She had 28 units of anti-venom. I mean, this is a big deal. And she was seen by ID, and finally ID calls me and they're like, Hagen, we need your help. This is crazy. And they told me this big thing. And I thought, well, gosh, I just met you. Let me see how this declares and really what's happening at the wound site. So I initially saw her 16 days after, which in my opinion was honestly a little bit late. I would have loved to be involved earlier, but no harm done. So again, debrided where we needed to, got off that necrotic tissue, and then again applied the Restrata in this. And you can see it before and after on this. This took a long time to heal, 6 applications. But one thing I really liked was that these applications lasted a long time. It was not a weekly type of thing. I did see her weekly for a while, just mainly out of my curiosity, but it really shrunk in and she completely healed and continues to be healed to this day. I think one of the things I learned from this is also just the expectations of, hey, when someone gets poisoned that badly, this is a huge wound. And I could have, as an alternative, really debrided all that necrotic tissue, could have done a skin graft or something like that as well. I think this is an exciting alternative. She was excited about it. Now, this guy is a periprosthetic total hip arthroplasty, and it got infected for the second time. And he had a it was explanted, had a spacer put in, and this thing was a horrific wound. And the guy's actually pretty healthy, and it went deep. And so we were able to apply this in. We did it under negative pressure initially. And then after that, we were able to get rid of the negative pressure. And what I think I love about this too is just looking at the scarring and how beautiful that looks. This was 5 applications. And what I really like is they were able to eventually put in his permanent implant, and he is doing great. I had different goals with these. So of course, complete wound closure is kind of the no-brainer goal, but sometimes it's taking people to a definitive procedure. So for instance, do they need a flap? Do they need split thickness skin graft? And I think all those things, I talk to patients all the time, like, hey, we might be using this as a bridge. This is my goal. But if we are doing really, really well, then we don't need that. We'll take those off the table the more we're promoting healing. And I think that's important to have those discussions up front. I think it's also important to understand what our patients' goals are. I had someone who needed a free flap, like legitimately, there was no way this was going to happen. I normally would, it was on his scalp, it was post-Mohs, and he just had exposed calvarium, and he was undergoing prostate cancer, undergoing radiation for that. He's like, no, I can't do it. I'm not doing that. And so I debrided the bone with a Misonix, and then I placed Restrata on there. And while he's undergoing cancer treatment, we got his entire scalp to heal. And this thing was giant. It was 10 by 10 centimeters. It was so big. I thought, there's no way this is going to work. And it did. He had to do his part. I did mine. And then I talked about that other case where sometimes we use these. And I think this is important. If you're giving someone something, they're going to palliative care, but it's going to be a while, that we can help with those transitions, help people care for them better. And this was the most amazing case that I got to walk with them through, of just getting her ostomy appliance to seal. And it really gave that entire family unit time together that was not, frankly, around poop, which was amazing on there. These are examples of other ones I did. Another cool one on there was frostbite. The entire sole of her feet were completely full thickness. She lost 8 out of her 10 fingers from this. This was the most severe thing I'd ever seen. And I honestly thought she was going to be bilateral BKAs, and we got away with doing transmetatarsal amputations. Another really exciting win for that. So we had a lot of comorbidities, and I really, when I look at wound literature, I don't want to discriminate against, the ones who pick the perfect population. I want to see the people who are like my patients, who are not perfect, because most people who come into the wound healing center aren't healthy and have a bike accident. They have a lot going on. And so I always want to see that these people are included on there. I'm not going to be able to compare all these patients to everybody. I did this study mainly is saying, like, hey, what is a typical day in general surgery, and how can there be such variation, and how can we continue to help these people? So I think this is a really exciting way to help bridge to healing on them and complete healing. So this is what I want to leave you with: dogs. And I always think about, like, I don't have a dog currently, and every time, like, my PA's dogs are acting them up, like, keep telling me about all the bad news on your dog so I don't ever get one again, because they're a lot of work. So, like, every once in a while you get that perfect golden retriever, you still have to brush them and do all that, but sometimes you get ones that are a lot of work. And so this acronym is reminding me of patients who come in that I see either in inpatient or in the wound healing center, is what am I handed, and where am I going, and what do I need to get there? So here's my acronym. What is going on? Determine the underlying diagnosis. Is it arterial, venous, infection, foreign body, pressure? Is it other, like PG? Like, what is happening? And then we need to optimize that patient. So diabetes, is their anticoagulation out of control? What are their comorbidities? How do we handle setting them up for PT, OT, offloading? Like, if they can't offload, I mean, I always say I'm not the Princess Bride. I mean, I can't bring someone back from the dead. I mean, they're not mostly dead. Like, you're either going to sink or swim, and I need your help on this. And that's not just my job. Goals, what are my goals, and do they match the patient's goal? I think this is critical that we are both on the same page for this. And sometimes I say, hey, look, I'm never going to be able to heal this, but let's try to stay away from infection. And I think this is important. And then strategizing those next steps. I'm always planning ahead. If I put an application in the hospital, do I think I'm going to need applications outpatient? How is that going to work? Who's doing those dressing changes? Is it family? Is it home care? How am I setting this patient up for success? And again, like, do they have the offloading pressure mattress? Where is their leg hitting? Is their diabetes under control? But this all has to be really planned out. So when you see your patients, think of dogs on there. And then I am going to hand this back off.
Now we're going to jump into Dr. Santosa's presentation. She will be sharing kind of her clinical insights of Restrata.
All right, perfect. Thank you so much, Carly, and thank you all for joining us tonight. It's an honor to speak about my experiences with Restrata over the past year. Just a little background about me. I'm Dr. Katherine Santosa. I'm a board-certified plastic surgeon in private practice in Atlanta, Georgia. I had the privilege of actually working with Dr. MacEwan when I was a medical student at WashU School of Medicine. We actually worked in the lab together and published numerous peer-reviewed publications. And I can say without hesitation that his science is robust, he's brilliant, and he's also just a very kind human. And with that being said, I was fortunate to match the University of Michigan Integrated Plastic Surgery Program, where I had robust training in reconstructive plastic surgery. I actually paused my education clinically to do a 3-year postdoctoral research fellowship back at WashU, where I did medical school, to try out some basic science work that I was very excited about at the time. I took a small pivot, did a fellowship in aesthetic surgery, and now I have a practice that consists of about 40% reconstructive work and about 60% cosmetic. So with that being said, I'm excited to share with you a couple cases that have exemplified the success that I have personally had with Restrata. I came to Restrata very happenstance. I was very disappointed with a competitor product that I had trained with and had lots of familiarity with. And it just so happened that I had an excellent sales rep in Atlanta who connected me and kind of gave me more information about Restrata, and has really taken off within my practice. I've abandoned all other wound healing matrices, and this is my sole one. So with that being said, this is a 41-year-old gentleman with very poorly controlled diabetes. His last A1C was 13 at the time. He also had other comorbidities, and he unfortunately was diagnosed with a DFSP, or dermatofibrosarcoma protuberans, over his right posterior shoulder. So the surgical oncologist performed a radical resection of the sarcoma. And you can see on the left-hand side that there's some exposed tendon. It's a fairly deep wound. It's about 1.5 to 2 centimeters deep. And although I probably could have gotten away with skin grafting, I felt like for him, with his poorly controlled diabetes and just what the wound looked like, that he would be a better candidate for Restrata. So the way I do Restrata is very similar to what Dr. Hagen presented. I do fenestrate it to allow an egress of fluid, just like I would with a split thickness skin graft. I use a fluorochromic to run and tailor tack the periphery, and I also tack it down to the wound bed to prevent it from shearing. Depending on the patient, depending on the size of the wound, I typically will put a negative pressure wound therapy dressing as a bolster, or I'll go old school and use cotton balls soaked in mineral oil, wrapped in Xeroform, and tie over some silk sutures. Here he is at 1 week, 2 weeks, and 3 weeks after Restrata placement. For those of you who are unfamiliar with the appearance of Restrata, it takes on whatever dressing material you apply. And so in that photo on post-op day 6, you can see it looks like Xeroform because that's kind of what I put on the base of the wound. At about 2 weeks, you start to see that Restrata break down, but you can see that healthy pink granulation tissue that's kind of coming through the white Restrata graft, which is very encouraging. And here at post-op day 20, less than 3 weeks after surgery, he has a beautiful, healthy bed of granulation tissue overlying all the potentially exposed structures of the wound, and just it's uniform, it's beefy red, it's bleeding, and for me, it's perfect for a skin graft. So this gentleman was actually a high school teacher, and so he needed to go to Disney World to bring his high school seniors to a special senior day at Disney World. And so he had said, Dr. Santosa, please give me the simplest dressing change. I don't want to have to worry about this. I need to ride roller coasters. I need to watch 120 high school students. Like, I need this to be simple. And so what we put on him was Adaptic, some ABD pads, wrapped him up in ACE, and we told him, don't touch it, don't get it wet. And we booked him for surgery the following week, which he was pretty happy about. So here he is at post-op day 28. I could have certainly skin grafted him earlier, but for scheduling reasons and mainly his trip to Disney World, we waited about 4 weeks. And you can see after I kind of cleaned up the granulation tissue and just roughhoused it a little bit, it is beautiful. It is bleeding. It's uniform. The granulation tissue is nearly kind of flush with the edges of the skin. And I put a split thickness skin graft on here. Following that, here he is at 1 week after his skin graft. Here he is at 2 weeks after his skin graft, and he actually had so much granulation tissue that we had to start cauterizing it with silver nitrate. But here he is on the picture to the right. So here he's about 7 weeks from his initial resection, and he's less than 3 weeks, and he has a perfectly healed skin graft, no issues. He's back to doing all the things that he wants to do. In a patient, again, who had poorly controlled diabetes, where I know that this was not going to be possible if I had just put a skin graft on him. So that's one of my cases. And here's the progression of his wound healing. So from application, and I think this is really helpful for those of you who are not as familiar with the progression of Restrata. This is what you can typically expect at week 1, week 2, week 3, and then here he is after his skin grafting as well. So this next case that I'm going to present, it's also my last case, but this is a case where I firmly believe that if this case doesn't convince you to even give Restrata a shot, I'm not really sure what case or literature may do that for you. This is a 68-year-old female with diabetes, other comorbidities, and who presented with the worst breast cancer that I have seen in practice. And again, I'm in private practice. I had never seen anything this bad, even at all the academic centers that I trained with. But she had triple negative breast cancer. It became unresponsive to chemotherapy, and ultimately she presented with this huge fungating wound that was malodorous and obviously was affecting her quality of life. So the surgical oncologist had called me about her, gave me heads up, and said that, you know, this operation that she was going to do for her was purely palliative. There was nothing curative about this. So my general surgeon performed right simple mastectomy, and you can see I also fenestrated it here and kind of tailor tacked it just like I had previously. So unfortunately, I put a negative pressure balloon therapy home vac on this lady, and my team and myself didn't educate this patient properly on needing to plug in the machine. And so over the weekend, she lost suction of the wound vac, called me, we triaged it. I thought we had kind of figured things out, but she presented on Monday morning on post-op day 7 with a vac that was not on, that did not have any power, and that had just a huge kind of puddle of seromatous fluid. And once we took that dressing down, I looked at the Acera sales rep and I said, you know, I'm sorry, we gave this a shot. We tried our best, but it was floating in the breeze, and I was pretty sure it was not going to work. But I was proven wrong. So here she is at post-op day 13, and she's getting that healthy bed of granulation tissue with us, pretty much not doing very much at all. We put her in an Adaptic, you know, sealed it off, put her in an ACE wrap and told her not to touch it. And then at 2 weeks later, she had this beautiful, healthy bed of granulation tissue. And because I needed her to go to radiation therapy as soon as possible, I booked her, or I felt like she was, you know, ready for a skin graft at this point. But due to scheduling reasons and her own desire to kind of postpone surgery, We waited until post-op day 29, or about 4 weeks after surgery, and you can see that the wound has contracted, which I have noticed is another benefit of Restrata. But she has this beautiful, healthy, uniform bed of granulation tissue that bleeds easily. And so it was a no-brainer. I put a split thickness skin graft on. I put her back bolster, and this time we did a better job of educating her on how to plug everything in and make sure it was charged. And here she is at 1 week after a skin graft, and it is beautiful. It is stuck on, it is adherent. I am not concerned about any areas of delayed wound healing. And of course, here she is at less than 2 weeks from her skin graft. So in total, this lady went 7 weeks from the time, I'm sorry, 6 weeks from the time she presented with that fungating breast cancer to this. And so she definitely had improvement in her quality of life. I was able to get her to radiation therapy immediately. And overall, I really can't think of anything else I could have done to get her this result and to kind of improve her quality of life the way we had with the use of Restrata. So with that being said, I'm sorry, this is a progression of her wound again. So just as a reminder, from initial presentation to totally healed, she is 6 weeks out. What I am finding is that when I stage my patients who would otherwise be candidates for a skin graft on that initial surgery, I'm finding that if I stage them with Restrata, give them 2 to 3 weeks of local wound care, then I skin graft them, I am still able to get them fully healed in a quicker time span than if I just put a skin graft on there and deal and futz with like a little, delayed wound healing here and there, debridement, sending them to local wound care, sending them to hyperbaric oxygen. So with that being said, Restrata has really saved me and has really improved my patient outcomes. So I often get asked from surgeons, colleagues, why do you use Restrata? I use it because simply it works. It's reliable, it's dependable. I've had more than 95% success rate using Restrata. I find it extremely convenient for patients. So patients come to my clinic and they get a weekly dressing change with one of my medical assistants or nurses, as opposed to a wet to dry dressing or Santal or something else that takes a 2 or 3 time kind of per day burden. I also like the fact that the less is more approach is the one that I use for Restrata. So the less I futz with it, the better my patients' outcomes are. And that was initially kind of difficult for me to understand as a surgeon, but the less I kind of mess with it, the better it performs and it kind of does its job the way it's supposed to. I also use it because it generates this beautiful bed of granulation tissue. Skin grafts definitely take better afterwards. And like, again, I'd said earlier, the time to full healing is much shorter when I stage with Restrata than when I try to go with a skin graft on its own, especially in these higher risk patients with poorly controlled diabetes, lower extremity wounds, obesity. And so with that being said, I really love Restrata. I'm a big fan of it. And I'm a big fan of it because it's worked and it really has improved my quality of life for patients.
Just touch on a few of the highlights on sort of how Restrata is working in some of these cases that you've seen, both in your cases, Katherine, and yours, Susan, as well. So Carly, if you want to flip to the next slide here. So I think it's important to understand because we get a lot of questions about, if Restrata doesn't have these exogenous growth factors like an amniotic, if it doesn't have any of these collagen molecules like some of the existing products that are out there, how does it actually work to facilitate all this great new tissue formation and wound healing that you've seen in both of these series? And so I think it's important to understand that the way Restrata works is a little different than a lot of those pre-existing products. So Restrata doesn't work by communicating soluble factors or growth factors to cells. It works by communicating these biomechanical and structural and topographical cues that are presented by the scaffold. And there's been a whole bunch of great literature out there in the publication space on how these structural and biomechanical cues work. And what all this literature really shows is that these structural cues inside of this electrospun fiber matrix support cell attachment, cell ingrowth, and cell proliferation. And so I think this is important to understand that Restrata kind of works in a different way. It works with a different mechanism of action. As a result, it provides kind of a new and a different tool in the toolbox. And like Dr. Santosa said, it works in some places where maybe other products maybe have failed previously or just don't work as well. The other important piece that I wanted to highlight here is just that Restrata as a synthetic engineered material has some unique properties that are different from other biologics. Particularly as Restrata breaks down, it forms these byproducts that are mildly acidic and has been shown to lower the pH of the surrounding environment. And interestingly, that reduction in pH potentially has a link to some other important factors. So one is that lower pH has been shown to move a wound toward a more sort of pro-healing state. And lower pH also has been shown to be linked to some interesting antimicrobial efficacy. And actually, we have a great publication that came out earlier this year that showed that Restrata, when tested on the benchtop, has been shown to have a 3 to 5 log reduction effect against 7 of the major pathogens that infect some of these wounds. So again, because it's synthetic, Restrata has some other unique properties that you might not see in collagen-based or biologic products. And then finally, one thing I want to mention is that I know a lot of the cases that you saw with Dr. Santosa and Dr. Hagen tonight have utilized the sheet forms of Restrata. So whether that's the solid sheet or the pre-mesh sheet that's meshed at a 2:1 ratio, like a split in a skin graft. Restrata is also available in another unique form factor that came out last year, which is called Restrata Mini Matrix, which is the first synthetic particulate for use in some of these irregular wound beds or to maybe put into more tunneling wounds. And so it's another unique form factor that's available now and that can be used in some of the places where maybe a solid sheet might not be the best option. So just want to highlight a few other sort of pieces of information here just to kind of cap off sort of this discussion of Restrata and some of the great clinical results that we're seeing around the country.